Hey, Joan. Hey, Fatty.
Hi, how are you? I'm
Good.
just staying off camera today.
Okay.
A lot of garbage behind me, don't want to see. How was your weekend?
Good.
Excellent.
Good. Are you back yet?
I'm back. Yeah, I'm back. Hey, but the one who's back is Joan, the world traveler.
Yes, I am back.
Did you miss us at all?
Nope.
Not one iota bit, right?
I missed my puppy dog.
Oh, thanks. Now we feel like we're not even as good as a puppy dog.
Hey, dog, do you have, Joan?
She's a chocolate cocker spaniel,
Oh, how old is she?
11 and a half.
Oh,
Yeah, she's a sweetie.
good.
She spent the week with Brandy and my daughter Brandy and her beagle. So she had a little vacation of her own. Here,
They get along?
Here, baby. Come here. Here's my girl.
Oh,
She's
my word.
been sticking close to me
Because you
since I
went
abandoned
away.
her. Yeah.
Oh, I love her little gray that she's got.
Yep, she's got a little gray muzzle going on.
Oh, my word.
She's my good girl.
She's beautiful, Joan.
Thank you.
So when she's with the beagle, who's in charge, her or the beagle?
Actually, the beagle pretty much defers to her, except at dinner time.
She's like,
And
I gotta draw the
she's-
line somewhere.
Territorial, yeah. Yeah, she was well cared for on her vacation, but she's happy to be back.
Good.
Okay, get in bed. Come on. She sleeps right here next to me.
Oh,
Do we have any idea what kind of turnout we're gonna get today?
so based on what I have in front of me, it looks like Charlie, Aaliyah, Craig's already on, Janine, John, Ada Ken should be on, and that looks about it. I don't know if Carol's going to be joining us or not.
Come. Here we go.
Joan and Fatty, I don't see anybody else in the waiting room waiting to come in. So we may have everybody that's going to be joining us.
Okay. That may be as good as it gets because it is vacation season after all. Okay, let's go ahead then. Get my agenda in front of me. Okay, so all right, so welcome everybody to the ProVantaCare IDD work group. We are picking up where we left off from our previous meeting discussions, and there's a few new things that we're going to review today that occurred since that last meeting. There was some activity we wanted to bring you up to speed on. So I'm Joan Martin. I'm the consultant to RCPA and to ProVantaCare. And ProVantaCare, I'm working with Fatty and you folks in the work group to primarily to work on the completion of the managed care position paper, or whatever we're actually going to formally call it. Tiana, do you want to run down who we've got on the line? You said you think you're not having any additions, so let's go ahead and see who we've got today. And you're on mute.
Sorry. So myself, we have you, we have Ashley Hirschberger, Carol Ferenz just joined us. Hey, Carol. Charlie Barber, Craig Douglas, Cynthia C. Miller, Fatty Sahar, and Janine Latin.
Great. So first, I want to congratulate Charlie on his recent election. That's outstanding that we'll have his leadership for RCPA for foreseeable future. So let's dive right into the agenda items. It's not a lot of agenda items, but each of them will have some healthy discussion attached to them.
I just want to say thank you, and flattery does work on me.
Oh, okay. Okay, Charlie, I will remember that. Great, thanks. The first agenda item is a carryover from our discussion regarding the HMA presentation. And we didn't get through all of it. There were some items we still wanted to delve a little more into about what we heard in that presentation. And we know that not everyone was able to participate in that live as it was happening. So it was recorded and that was sent out to you so that you could review that presentation. And we're specifically pointing you to the section of the presentation of the three different presenters that really focused in on IDD managed care across the country, and some trends and things like that that the presenter was observing. Fatty, I'm gonna let you take it from here on what you wanted to have the folks really
Joan,
review.
I'm sorry, I
and
know you're asking
consider
me a question.
the key
I'm a little
items.
bit offline for a minute.
Okay. Okay, so Fatty's offline for a minute. Okay. Okay, so let me go back and just kind of point you to what we wanted to review today. I have my presentation up on the screen, so let me go to it. Okay, what happened to it? That's not it. HMA, there it is. So Health Maintenance, Health Management Associates was the presenter, and the section of the presentation, the panelists that we want to focus in on a little bit is the presentation from Sharon Lewis, who was very involved in the Department of Health and Human Services, and was very involved in establishing the Administration for Community Living, which is the HHS division that was established in 2012 that includes all of the home community-based services. It also has the Centers for Independent Living and a lot of aging programs and so on. So that was her world. So her presentation had to do with the IDD landscape. So the section of that, let me scroll down to it. This was a long presentation, but very informative. So the if you go to the printed, the screenshots from the presentation, it is page 16 of the presentation. Oh, I'm sorry, that's the LTSS. No, I'm not there yet. Behavioral health was first. Oh, behavioral health. IDD services landscape. Okay. So that presentation is at slide 46. So the presenter kind of added some additional points to a timeline many of us have seen before. This organization has used in other presentations. You may have seen it at conferences and so on. And they've added 2019 and 2021 activity that is showing what has happened since then. So the conclusion, or conclusion isn't the right word, the observation that the presenter was making was looking at what has happened to efforts to use managed care for intellectual disabilities and autism across the country. And in some states, that is developmental disability service packages. Where in Pennsylvania, it's IED and autism, because we don't serve people in a DD construct. That's one of the things that's different about Pennsylvania compared to other states. So they did some comparisons and looked at some integration initiatives, which really points to places where the acute care, the physical health, and the intellectual disability or developmental disability, and the behavioral health components are combined, are provided together. And she reviewed those places where that is happening or is scheduled to happen. So let me stop there and take questions or observations from the group if you've had time to look at the presentation, if you weren't able to hear it live. And we'll start there with following up on our previous conversation and some observations that Fatty had made shortly after we had heard this information. So I'm opening the floor up to the group on the line.
Well, you know, I know the one lady made a comment toward the end about the quality in Pennsylvania under the current system is quite high in comparison to other states. So I was wondering in any of the information they provided us, when they were talking about other states that have gone to managed care, was their baseline equal to Pennsylvania at the time, or was it below Pennsylvania? Because even though if it was below Pennsylvania, and depending upon how far below Pennsylvania it was, that would kind of give us an indication of if they went to managed care and they're saying they're doing better than they did pre-managed care, does that mean that their standards have now come up to Pennsylvania's, or are they still below? Because there has to be some baseline that we're comparing
Right.
apples to apples on.
Yeah. Yeah, it would be nice if we had nice apples to apples. But states are so different that I don't know if we'll ever actually have that. But I think that in her remarks, one of the things I heard her say regarding quality, and you're right, she pointed out Pennsylvania in where they are, and we are further ahead in the use of the core indicators, much more so than other states. We've been doing it longer, and we've been doing it for more pervasively across our system than other states who just brought that in when they brought in managed care.
Yeah, because I noticed, I mean, the states they're using are like Arkansas, Tennessee, places like that.
Right.
And, you know, you get south of the Mason-Dixon line, I don't know how well they've been in health and human services over the years. You know, I can remember Jimmy Carter when he became president, and he was trying to extrapolate like how Georgia performed in mental health state hospitals and assume that that was like an equal across the country, which wasn't even close, I'm sure, you know.
Mhm.
But then he wanted to implement things based off of what he had seen in Georgia. So, I mean, I just always wonder when we're talking about these states. I mean, Arkansas is usually like 49th in the country and everything. Like, is that really, you know, like, you know, is that really like a place we should say, oh, well, you know, they're doing better now, and therefore that's a legitimate direction to go in, or implementing like what they've done?
Yeah, well, I think what the conversation is going to come back to in trying to make those kind of comparisons over time is that the nation currently lacks a standardized way to measure those things. There isn't a home community-based services standard to use as any kind of yardstick. So I think what you're seeing in some of these states where they introduced IDD into managed care, for some of them, the benefit or the raising of some scores compared to pre-managed care is not necessarily the home community-based services part of what they did, but maybe reflecting the physical health improvements in having managed care. Things like more people got their flu shots, or things like that, that were part and parcel of when they got the program off the ground. It was their first managed care on the physical health side as well. So again, if there's no apples to apples here, because Pennsylvania has had managed care for their acute care, their physical health care, for many, many, many years. So we we would like to look only at what would happen if IDD was added to that, where in these other states, they did both of them together. So it's hard to tease out where the benefit really occurred. So that's tricky. So I did also along the same lines regarding the quality discussion and measuring quality. The CMS put out a request for information on home and community-based services quality. And in the slide that Sharon presented, one of the things she lists that is going to be impactful in the future on this topic is the CMS response to the home and community-based services quality RFI. So that effort is trying to make a national standardized way to have some measurement, some baseline things across the country that eventually will be an apples to apples thing. But we're just in the beginning of creating that on a national basis. So all we have currently is some proxy quality measures in the meantime. So that is one of the things that has held some states back from taking further steps, is they don't really have a way to measure it. You know, what are they going to get for their effort if you don't have a good baseline, as you say, you know, to start with.
Thank you.
You're welcome. Any other comments on Sharon's presentation?
Joan, I apologize. I had to pick up another line that just came in. I'm assuming that the summary of it is that this group recognizes that Sharon's is not the only point of view, that managed care is going away and never coming to us. Right?
Yeah, that would not be a conclusion that I would say that she was trying to get across. I think looking at her material, and I've heard her speak before, and I've seen her presentations before. I think that the bigger takeaway is that that where states have experimented with this, they're still experimenting and tweaking and changing, and states that we don't yet see, you know, on her chart. I think some of that reflects, as you know, there's a gap here. So 2020 really put some brakes on some things, including some of these managed care ideas. So I think as we come out of the pandemic and people begin to get back to normal, you know, in terms of programming and so on, and states begin to incorporate the shot in the arm of the money that they'll get from the 10% American Rescue Plan Act funding, we'll start to see more things happening. Particularly, I believe we'll see a lot more receptivity to demonstrations and pilots and things of that nature that were not possible in the last year and a half, you know, to even be considered.
Yep.
So I guess that piloting and demonstrations is one of the things that we, as ProVantaCare, would support rather than, a designed new program that is then imposed, statewide without knowing whether it actually would work.
Mhm.
Okay, any further comments or questions on the HMA information? And you did receive both the presentation itself and the recording if you wanted to hear her remarks as she went through her slides, if you would like to go back and review that. Okay, let's move on to the next topic. The American Rescue Plan response, which Fatty gave Tana to send out to you in preparation for today's meeting. So I'll let Fatty walk you through that.
Hi, folks. I'm opening my document, but just to give you some background, we were given essentially like 10, 12 days to put this together and get it back to them by July 6th. I know many of you participated in a number of conversations around what we would do and what kind of activities we would recommend that the state undertake in this particular opportunity. Now, ProVantaCare in this situation wrote a separate paper or response to the state, independent of RCPA. And I don't know if many of you received the RCPA document, very comprehensive, done by division and by addressing the individual services in a very pro-advocate perspective. In preparing for the response from ProVantaCare, we, again, one of those obvious situations where we need to be separate and different, we took an approach of we are dealing with an opportunity for a contracting opportunity for the providers and in the ProVantaCare network. Rather than saying we want to advocate for everything and everybody's equal and let's all do kumbaya, we literally said, hey guys, this is money that's going to go away in 3 years. As you do what you're doing, we want you to make sure that you utilize these money in ways that help you guide the future and help you specifically leverage the things that you say you want to do. So in the various segments, and I'm sure if you have a chance to read it, it's not that long. It really focused in on how you can leverage the network to learn and set up some of these pilots and fund some of these VBP opportunities that the state is talking about wanting to do, so that they can actually have factual data in their hand. And we also leveraged the conversation about where technology and relationships, that because we are a single signer authority, we're able to tackle some topics a little more aggressively than individual providers could. So for example, where we are dealing with some of the behavioral health conversation, we talked about the relationship with the HIEs, where we're bringing in technology and even with the IDD world, the two biggest area from my perspective in IDD were how do you validate the use of technology? And why don't you fund us so that we can work specifically with providers so that we can demonstrate how technology supplements and supports consumers to live independently in the community? That was one. The other big one related to IDD was the whole CHC conversation, where there is, we think, up to 6,000 consumers today who are in the CHC waiver, and they are actually not receiving the services they need. I know I'm looking at Janine, and she probably knows more consumers in that boat than most, because they are, they end up being assigned, and the only tool in the toolbox there is essentially PAS, and that's not what these consumers need. And so, we basically, in the response to the state, said, we have knowledgeable, capable, skilled providers in IDD and who are working with the CHC MCOs. Give us the opportunity to give you proposals that we can leverage into ways to address these challenges. So we don't end up, and we didn't use those words, we don't end up with a de facto managed care world that is community-based program for under CHC, and that is residential under the current waivers. Which, left to its own devices, water will find its level. So it's I wouldn't be surprised if some of those things start to happen. So I don't know if you've had a chance to read the response we wrote. The one area that was kind of controversial, and I did stick to my guns on it, was that there was a proposition that registries should be used as the pathway for identifying and hiring DCWs and direct service professionals. And for those of us who've been in that fight for 10 years or more, I thought it was important that we voice a concern that should be a pathway rather than the pathway. And so I welcome input, and what I would say is going to happen with this paper is Jamie Buchenauer and Kristen Hauser and Kristen Ahrens have been out, and with a bunch of other commitments that they have. I am setting up meetings with them directly in the next 2 weeks. They've all responded positively to want to consider some of the stuff that we're putting on the table. And I will come back to this group, in particular to the IDD related opportunities around use of technology and what we do with CHC in particular. Because we will probably need to, if they will say yes, give us a proposal. They're not going to say no, is what I've been told. They're not going to say no. They're going to say, give us a proposal for what you want to do. So at that point, we probably come back to you guys to help us formulate what that proposal would look like. Any questions or concerns, or if there is an additional, as you read this in this context, as you read the document in this context, please send me any feedback. I welcome it for one, and the other is recognizing that this is just the first volley in the process. This is not by no means the end all, nor does it mean that the state's going to do anything that we ask them to, because from talking to Jack Phillips, there's a predisposition in the legislature to keep as much of the money away from being spent in the next 2 years and reserving it for sometime in the future. So we'll keep our ear to the ground on this one. Joan?
That was a good review of our thoughts that ProVantaCare has sent up to the folks at DHS who asked for it. And now we'll see what kind of interaction we can have as they actually develop things. They got lots and lots of feedback from lots and lots of people on how to use this money. So I did want to also echo Fatty's comment that he shared um, from Jack, that the time frame of the use of this funds, because it is quite a long tail on the use of the funds, it extends into 2024. So there's no hurry. The state is not feeling that they have to put something together. Sometimes when money comes out, there's a very short turnaround to say exactly how you're going to use it. This isn't one of those. They can take their time, which will benefit us to put something thoughtful together, getting consensus from the group and really putting something meaningful in front of them to consider. Just also keep in mind as you look at the calendar is that there will be a gubernatorial election next fall, not this coming fall, it's next year. So to the extent that some funds can be held back, if you will, and they are allowed to do this, they earn the money in a short period of time. It's only about a year that they actually earn the money. They put it aside and spend it much, much later. We may see some of those things being held, some of that pot of money, so that the next governor can put his preferences and priorities on what happens. So that's just kind of keep in mind, because that's the way the world works when there's federal money and state appropriators deciding what to do with it. I just wanted to mention also that the things you see in Fatty's paper are with the ProVantaCare hat on, and our CPA as a trade association weighed in from that perspective. So they're not identical and they shouldn't be. So just, if you look at the two side by side, you'll see that there are some differences in what the two opinions were in regard to this funding. Any other comments or questions or discussion on the American Rescue Plan information? Okay, so the third item on our agenda today is a follow-up to the previous meeting where we basically ran out of time and put it forward to today to pick up where we left off. So there were items of consensus that we were running through to help us think from a high level regarding managed care for intellectual disabilities and autism, what that could look like and where the different locus of power and responsibility and authority and oversight would reside, because there are many different ways to do it. So we had gone through things like provider networks and what that would look like and who calls the shots on that. We went through determining provider rates and how that would work and who has ultimate control over that. And then we talked through who should do the assessment of care needs, and then who should issue the service authorization. So that's kind of the world of AE, SC, VP regional, those kind of things is how those things could happen, but also be related or not related to each other. So what we didn't get to was a discussion regarding supports coordination per se. which is a function that has to be incorporated somewhere. So you always need the function of, we call it supports coordination, but coordinating the services, if you want to kind of look at it generically. So that's what we want to discuss today a little bit more in depth and go through some of the options, and then think through, what we would like to flesh out and perhaps recommend, or a caution against, based on how that could work. So before we jump into supports coordination, I wanted to give the group on the call today, and I know some of you were with us in the discussions that we had on the first set of discussion topics for consensus. Are there any issues from that previous conversation you want to revisit or ask about before we jump into supports coordination? Okay, then let's jump into supports coordination. So let me just quickly review what I have under the consensus building items, and then we'll get into a discussion. So the discussion is, there's really two things that supports coordination can be, two ways to provide it under CMS when you're using Medicaid money. It can be a waiver service, or it can be an administrative activity. So those are the only two choices. It's either fish or fowl. There's no other way to do it. It's one or the other. It's either a service or it's an administrative activity. So the things I want to describe today is ways that those two things can happen, and what some of the benefits or strings that are attached to each one. So first, let's talk about waiver service, supports coordination as a waiver service, which is what you currently have. Your sports coordinators are fee for service, any willing provider, service providers. So when the state sends their invoice to the feds for this activity, this waiver service, that they get from service coordinators, 15-minute units at a time, they take that, send it to the feds, and the feds send back their portion of federal matching funds. So it's currently, the state pays 48% of the tab, and the feds pay 52%. So that is a service FMAP. And we currently are using any willing provider. So a provider who wants to become a supports coordination entity can meet the qualifications, become a waiver Medicaid provider, waiver provider, and they can then hang their shingle out to be a sports coordination organization. So that's what we currently have. The other way a state can provide support coordination and have it still be a service. In other words, they capture the activity unit by unit and get the 4852 federal matching arrangement. And that is by procuring the service. So that's a competitive RFP that states the approach the state wants to use to have enough service or support coordination entities to serve the people in the program. And they would have to have choice. So if it's a service, you have to have choice. So there has to be at least two. And the state has to assure CMS that they have statewide coverage. So they have to have 2 choices everywhere. So that's basically what that means. And that, again, with the limited number that the state gets from an RFP, they still get the 4852 federal matching funds. So that's sports coordination as a waiver service.
Joan, don't they also have to demonstrate network adequacy?
Nope,
As
not
part
for
of-
fee for service.
Not for fee for service, okay,
Nope, nope.
okay.
You just have to have choice. Yep, network adequacy comes into play under the managed care.
The managed care, okay,
Yep.
thank you.
Yep. Okay, so any questions or discussion around, again, the context of this conversation is that if intellectual disabilities and autism services go under a managed umbrella of any kind, what should happen to supports coordination? So this is kind of, thinking what it could be compared to what it is. Not saying that what it is can't survive, but there are other ways to get supports coordination that we see happening when a state also brings in a managed component to that service.
So Joan, can I ask a question? If you
Sure.
did it underneath the second way under service, does that have to be then put out by the state? Or can it be done like mental health choices by county for choosing the 2 or more NGOs?
Well, that's a very good question. It has been done both ways, and as you see in Pennsylvania, we have done it by a county right of first refusal. However, I would say that the likelihood of being able to use that particular model would depend on who's calling the shots at CMS and whether they would entertain that or not. We've seen administrations at CMS where they do not like that model, and they would not approve using that again. And in fact, they did their darndest to make Pennsylvania stop doing it, but they lost that fight. So I don't know what would happen if Pennsylvania asked to use that model in another system. They were left alone ultimately to keep using it in behavioral health, through the counties. Whether that would be approved in another setting is really unanswerable at this time.
So when you say that they lost that battle, is that back in the 1990s when they first went?
No,
Or is that more recent?
No, it was very recent. I'm gonna say probably maybe 4 or 5 years ago.
So it was under Wolf.
No, Wolf had nothing to do with it. It was CMS that wouldn't.
No, I mean, it was during the term of Wolf, or was it during the term of Corbin? You're saying
Yes,
5
probably.
years ago would be Wolf.
Yes, probably. It was probably Wolf. Yeah. Yeah. And so they defended it, asked to continue to use it, and had to really go to the mat with CMS to be able to do that. And there were states that, because of the saber rattling at CMS over this very issue, they ended their county arrangements similar to what we have. So we don't know. That's a very good question that I think time will tell whether that's that will be entertained or not. Okay, so let's go to the second way of getting supports coordination under Medicaid. And the other alternative is that it is an administrative activity. So that means that the state does not get the 4852 deal. They get 50-50. Administrative services, administrative activities are a 50-50 FMAP. So you can do the math that if a state is going to elect to make it an administrative activity, they lose some federal matching money. But they gain in some other ways that they think are a reasonable trade-off, and that's why they ultimately choose to do it. So to make it an administrative activity, it has to be procured and contracted. So they under administrative activity, they do have to ensure statewide coverage. And the example that's the same concept is that the way financial management services are procured. So in that example, the state procured a vendor to do financial management and ensured statewide coverage by requiring that vendor to operate in every county, serve people in every county. And they don't have to offer a choice, but they can. They can have 2 or 3 or 5 or whatever. So they can offer choice, but they don't have to. They can procure one statewide vendor. So if under managed care, using that model to have it as an administrative activity, the ODP could require that the managing entity, whoever that will be, that they use the state procured contractor or contractors. And again, that's exactly how FMS worked. When CMS, or when Community Health Choices came in, the state had already procured an FMS vendor. And when Community Health Choices was put in place, they required all 3 to use that one OLTL procured vendor.
How's that working out?
Well, it depends who you ask how that's working out. There are people that are very happy with that model and people who are very unhappy with that model.
They've increased the number of nursing facility eligibles, right?
Well, they have no interaction with that.
Oh, I thought they were the ones who determined.
No, that's a whole different vendor. That's Maximus, who does the front door for OLTL.
Okay.
Yeah, that's a whole nother conversation. But with FMS, that's the people who self-direct their services, the financial management service. The people who are not happy with how that's working are the managed care organizations and the state, because the current situation has that vendor, the state procured vendor that the MCOs are required to use. The state is in the middle of that deal, that partnership or that arrangement, because it's the state's vendor that they require the MCO to use. So they are now in the process of changing that, and the state is getting out of the middle and allowing the MCOs to procure the FMS vendor directly themselves. So it's their vendor starting January 1 of 2022. So basically, the reason it is the way it is now is that the state really had no choice but to extend that contract through the launches of the CHC. Because to do both of those on top of each other, and both have to happen on January 1, A, that's the managed care contract year, it's always a calendar year, and B, the tax year is when you change FMS providers. You don't change in the middle of a tax year. So they both have to happen on January 1. And because of previous issues with smoothly going from one vendor to another who does this FMS work, they very wisely saw that they shouldn't put one on top of the other because it would not go well. So they didn't. They extended the contract. So now that all the launches are done all across the state, now they're going back to that FMS issue, and the solution is MCOs, you procure it now, from now on. So that same kind of arrangement could be used to get supports coordination as an administrative activity, whether it's the state's administrative activity vendor or the other way would be the managing entity could do it. So the next bullet point.
And then, Joan, we may want to explain here that in some states like Arizona and New Jersey and even some extent Tennessee, they've kept service coordination as an administrative activity, but gave it to the state, where the state actually, it's a state department that does that administratively, not as a, so there, the model exists out there for Pennsylvania to do it in a variety of ways that are going to be approved. But there's the biggest issue is whether if they keep it as an administrative function, they could keep it as a state managed activity, or they could have it be an MCO managed activity.
Right. So on my list of ways it could be done in Pennsylvania under managed care, I did not list that the state could directly provide service coordination with their own state employees, and I'll tell you why in a second. So the states Patty referred to, Arizona, New Jersey, Tennessee. Arizona never had any other model. Those people that interact in their system to do the supports coordination, do the care plans and the service authorizations, they never were outside the government. They've always been internal. And Arizona is a one-off. There's nobody like them. When they first went to managed care, they never had fee-for-service first. It's the only state who ever did that. So in other states, they had fee-for-service and then they converted to managed care. Arizona came out of the gate. Their very first Medicaid program was managed from day one, and the state retained the service coordination function, supports and service authorization. Tennessee has a hybrid going on right now where some of the SCO work has been turned over to managed care organizations in some of their programs, their new managed programs, but they're keeping it for some parts of their system for now. That's how their documents read, that they're not turning that over at this time. They reserve the right to turn that over to managed care later. They also reserve the right to turn over the setting of provider rates later. So for now, they're keeping it the same, but they reserve the right to turn that over now. So what I've never seen a state go backwards. In other words, from managed back to fee for service. It always goes the other way. So could Pennsylvania use that model like Arizona and have those supports coordinators be state employees? Yes, they could. That's a model. CMS would probably approve it. The problem is that the state would need so many more new state employees to do that. They call it complement. They would have to have lots more complement to pull that off, to have them be state workers. Every governor that I've worked, every administration that I've worked with since I started this almost 40 years ago, has bragged about how they have reduced state complement. That is one of the hardest things to get, is more state complement. So I didn't even put it on the paper as an option, because it would take, think about how many folks do service coordination across the state for this system. And to think that the state would say, I want that many more employees that I have to pay by the civil service scale and give them pension and health care, is not going to happen. So technically it's a possibility. It's one of the options that CMS would approve, but I don't see any way that Pennsylvania would be allowed to propose that to CMS. Okay, so the other way for it to be an administrative activity is that it's contracted by the managing entity with choice of supports coordinator. So CMS does require that the person have a choice of supports coordinator, not a choice of supports coordination entity, but of coordinator. So if I don't like Jane, I can have Mary. Not if I don't like this company, I can have another company. So that's like the most elementary iteration of choice, that if you don't like your service coordinator, you can ask for another one. So that is an extremely low bar in terms of guaranteeing choice. But that's all there is under managed care. They will not, CMS does not require that there's an offer of another entity for the person to choose. And then another option is that the employee of the managing, that the service coordinator is the employee of the managing entity with choice of supports coordinator. So again, whether it's by contract or by their own direct employee, that very, very basic choice of individual is all they have to guarantee. Okay, so discussions between the two approaches, service or administrative activity. Both can exist under managed care. And the benefits and uses of the different approaches partly has more to do with what functions that person is going to do and what authorities the managed care organization has versus authorities that the state wants to keep control over rather than turn it over to the MCO. Any thoughts or discussion or questions on that?
Joan, why would there be any question that we would want it to be a fee for service in order to preserve our current owner group position in this world?
That is the option that gives a group such as the ProVantaCare owners the least benefit.
Walk us through that, please.
So under fee for service, any willing provider, let's just take the first one. There is a relatively low bar for additional providers to be in the mix. That frankly is why OLTL went the other way because they pretty much had a mess on their hands, leaving so many providers in to do service coordination. They were unable to clean it up because it's fee for service. The state has very few weapons to do that because of Medicaid rules. So the more providers there are, the harder it is for any one provider to have any benefit, to stand out or to be paid any differently, because under that model, you can't pay anybody differently. So a service coordination entity that, or I'm sorry, supports coordination organization that is doing a fantastic job under fee for service gets nothing more than bragging rights. You don't get any more business, you don't get any more pay, you don't get any other benefit out of that by far surpassing your requirements that you have to meet to be a provider. So under managed care, if there's no way to get a distinction or get to be preferred or get a different payment, fee for service would block that as a way to pursue that path.
Joan, would there be any possibility for, the fee for service model to still be in place as a waiver service, but the stipulations on how to be a qualified provider have changed. So you'd have to have, experience in it outside of managed care. You'd have to meet certain requirements under the QA&I reviews, achieve 90 or higher, or 95 or higher to be, able to be a qualified provider as managed care rolls out, because we do have a lot less SCOs and NPA under IDA than OLTL had. We're only about 55 right now. And a lot of the SCOs that are embedded within the county, their models are going to be changing, when this rolls out one way or the other. So that might decrease as well. I'm just thinking, I'm kind of stuck on the waiver service side because I feel like almost that's most fair to providers. That's the way that we could, all survive and still be able to grow our business in one way or the other. But, I don't think that we should, let any willing provider be in the network if they're not a quality provider. And, we have history of quality providers already established in PA.
Could we require them to be ProVantaCare owners?
I doubt the state would agree with that.
Actually, it's worth a try.
Yeah, that's a great idea. We'll certify. Yeah, we'll be your funnel.
Would it make sense though to advocate, to Ashley's point, to take a position that there needs to be a higher standard and that it should be a managed network rather than independent entities?
Any other thoughts on that?
Well, I just want to say, I think Ashley, has some good points there. And I also think that that there could be a requirement for size too, so that you have the organizational scale in order to perform, what would be required. You'd have to be able to assure that you had the ability to do things.
Mhm.
Because that was one of your problems with the SCEs. You had a lot of very small SCEs that really weren't capable of performing underneath a managed care function. I don't think they're able to really perform well underneath the old system as it was.
So let's talk a little bit about what you can do under fee for service. And that's the any willing provider. So the state's hands are tied on what they're allowed to bake into their floors or their thresholds to be a provider. So they're allowed to do things like requiring key people to have experience in the population subject matter that they're seeking a provider for. They can require training and screening and things like that of the actual service providers, in this case, the service coordinators. They can require the organization to meet quality benchmarks in how they deliver services. So that's all, you find that in the waiver provider qualification section of every single service, what the deal is. The minimum age, everything's in there. What they're not allowed to do is exclude a provider from being able to take the first step by requiring them to already be at a level you can't achieve unless you already are one.
Mm.
So scale and having previously met some kind of threshold that you can only achieve by actually doing it would not be permitted under fee for service.
Could it be licensure of some sort?
Yes, licensure is totally fair game. CMS actually loves that when you
I mean, could
say
it be
our threshold is a license.
certification or licensure? Like I know
Yes.
some states require CQL and in their case management for IDA.
Yes,
There are other states that could be, I mean, could we, as a way to address some of what both Ashley and Charlie are saying, just like we proposed NCQA very early on for SCEs, the reason we proposed that is we knew that the plans had to have that accreditation in order to be able to meet their contract commitment. If the state were to build into a managed care environment a quality standard that literally says when this is an all-willing provider who can meet this quality standard, I think we could both benefit our narrow the gate to what to Charlie's point, but also to attract the help our own providers in ProVantaCare rise to the top or be the first prepared or be the just like you did with brain injury with CARF accreditation type issues. I don't know what others think of that.
Well, I think there should be some kind of hurdle that you have to get over in order to make it a legitimate proposal, right?
Yeah.
Mhm.
Instead of just saying it's open to everybody. I mean,
Yeah, I think like the licensure would be a good idea as well, because, the smaller agencies, they probably don't have the time and resources to be able to do so. And that would help with like the size component that Charlie was talking about. And then you're going to be most vested into it if you're going through this process and doing that work. So, your quality measures are going to be hopefully in line and equal to that investment that you're putting in to get the licensure as well.
Do we want to be specific in the licensure? Do we want to research it and recommend something, or is there something that is the natural licensure in this environment? Like, for example,
I'm not aware of anything.
on the PAS side, for those of you who may be familiar with it, CMS has 3 deemed accreditation agencies, and they basically treat that like going to college. All you need is a college degree. It doesn't matter which one of the 3 you get, as long as you have an accreditation from one of those 3. And I'm wondering if there is in the IDA world, a similar, I mean, the only one that I know about is CQL. But I don't know whether it's good, bad, or indifferent in the case management side or service coordination side.
Patty, what state did you say had CQL?
I know that Tennessee uses CQL for some of their residential programs. Ohio does that for a lot of their programmatic side. I haven't seen it specifically done for service coordination, even though
Okay,
I know that case management and service coordination are part of the CQL book.
Fatty, what about NCQA for service coordinate, supports coordination in this services?
I know, Ashley, you've done it. How's it feel? I mean, NCQA would definitely say it's a health plan accreditation.
right.
So if it has a health plan equivalent, I just want to keep it. I want to make the MCOs work harder to move it in-house than to say, well, it's NCQA and we'll just do it with our, we'll use our health plan rider on it, essentially, which is what they did with CHC. But NCQA could be an option.
Yeah, I feel like it's much more clinical based and medical based as far as case management goes. So I don't know. I would like to look at some other options.
Okay.
So part of the conversation about waiver service, as a waiver service, particularly fee for service, any willing provider, it's very difficult to have any distinguishing treatment because Medicaid requires states to treat everybody the same floor, same payment, same rules. So taking that same thought about the quality of service coordinators and retaining the floor so you don't get the mess that OLTL ended up with. But allowing it to have the ability for outstanding providers to be preferred or to be paid differently or better than others, that's where the management of the network comes in that Fatty alluded to. Any thoughts about that?
How would you see that working? Like, yeah, how would you see them put that together? So that'd be like an annual evaluation that allowed for being paid differently?
Well, the way some states do it is it's part of a renewal process, like reaccreditation type of, what do we call that? Recertification every 5 years or something that we do.
Yeah, that's revalidation.
Revalidation.
Yeah. Yeah, but you can't attach quality to that.
I can't.
Nope.
Okay.
Nope. That's recertifying your floor
Okay.
to be a Medicaid provider.
Prime.
I'm struggling to think of a way to have network management where you have the ability to be paid better or treated better because you're better in a fee-for-service environment, because those two things are really not compatible concepts. I think there has to be somewhere along the line a managed authority in order to pay service coordination work any differently than the next organization that meets the qualifications as well. And that includes in who gets the business. There's no way to treat the entities differently under fee for service. You can't prefer one over another. You can't pay them differently. You can pay them differently by geography, like you can pay Philadelphia differently than Clearfield County. But the two providers in Clearfield County have to get the same rate.
Mm.
And there's no way to change that geographical structure to reflect a quality structure.
No, fee for service cannot have quality baked into it.
Well, and that kind of became a problem in the prior years where they had level 1, 2, 3, and 4, where if you were an organization in multiple counties that had different levels based off of what they were going to pay the different levels, then the question was, are you paying me for like where my headquarters is and I'm billing from, or where I'm providing the service, or how does that work? I think that became a problem when they were doing those enhanced rates.
So should we just, for purposes of this paper though, talk about enhanced rates for demonstrated, like think of it from a value-based payment perspective, like a performance base that, that meets certain criteria, that the SEO meets specific criteria? I mean, do we insert the concept of value-based payment in here? Because as a way to basically make it more challenging for the less sophisticated providers, for lack of a better term.
Well, I'm not against that. I'm just not always sure how they.
I'm not, we can flesh it out if that's something that you guys think would work. But I mean, we're inserting a significant change then into the way things work.
So following Fatty's thought process about having payment in some way tied to value or tied to quality, we need to think through where the managed authority resides that allows that to happen.
I agree with that because, now the way they do it in mental health, it's based off of who the MCO is
Right.
in the county. And so different MCOs do it differently, right? So there is no apples to apples there either.
Mm-hmm.
So who should?
The state would be the only entity that's statewide that could do it.
And the state cannot do that under fee for service. In order for the state to do it, it has to be an administrative activity. And there has to be, if it's an administrative activity, the state can put into their procurement documents quality standards that they enforce. So I think we have some more thinking to do about where the interplay between what we want, which is quality supports coordination, versus how to get some benefit of being a quality support coordinator in ProVantaCare. How do you get any benefit out of that? More business, better pay, some other benefit that you can't get in fee for service. So I think I just shot the rest of our time, didn't I? Yeah.
Yeah.
All right, so we covered a lot of ground today, and I think we have a lot of things to still think about before we can conclusively say what we want to do here. Patty, maybe a couple of straw men might help people.
Yeah, that's what I was thinking too.
One side or another of some of these concepts.
Well, we have a couple of weeks before our next group meeting. Why don't you and I brainstorm, set up a brainstorming so we can send out maybe 2 or 3 ideas for folks to consider before the meeting.
Yeah, I like that
Because
idea.
I think that if they have a chance to read it and think about it, I think we would end up in a better place.
Okay. So it's equally valuable in terms of this position paper, in my opinion, for us to say, we would consider these kind of arrangements in order to achieve this goal. We do not want this kind of arrangement.
Right.
We've identified some things that we believe would not work in our system.
Mm-hmm.
All right, let's shoot for that. And our next meeting is Monday, July 26th. And again, it's 12 to 1:30.
Yeah, I just want to say thank you because today's meeting was probably, for me, the best we've had. You did a very nice job of explaining all the different things, Joan.
Thank you. The more we peel it back, the more we can see what the possibilities are, what the pros and cons are. All right, thank you, everybody.
Thank you,
Thanks,
everybody.
Joan. We'll go to
Thanks.
Jan.
Bye-bye.
Bye-bye.